It's Dr. Cassie Smith, and welcome to Back to the Basics, a simple approach to health in the modern world. I appreciate you taking the time to join me today and hopefully learn ways that could help you improve your health. The modern world has left little time to focus on health and wellness. I hope to give you some quick and simple ways to be well and live your best life. Welcome back to this week's episode of Back to the Basics. Thank you for joining me. I'm excited as we continue our journey to get well. I'm beyond excited to have my next guest here today to talk to you about a very important topic, hormones and sex. Dr. Peet is a board-certified OBGYN who has been practicing for 24 years and is well-versed in hormone replacement therapy and sexual wellness. We're going to ask him all the questions you want to know. Does hormones cause cancer? Is erectile dysfunction normal? Why don't I want to have sex with my husband? Make sure that you listen to this entire episode. You may want to take notes and even send this to a loved one or a significant other. If you find this helpful, please consider leaving me a review. Now let's get this heated conversation going with Dr. Johnny Peet. Hello, everyone. Welcome back to this week's episode of Back to the Basics. I am very excited that you joined me today. We're going to talk about something a little different. It is still incorporated in my 10 stages of wellness. It's at the very top. So we're going to be talking about sexual health and wellness today. And so I have a OBGYN here. So I have Dr. Johnny Peet. He was born in Dallas. He was raised in Conroe, Texas. He went to the University of Austin for undergrad, UT Austin, and then he went to Texas A&M for medical school. He went to Scott & White for his OBGYN residency, and then he's had a private practice since 2000. He's now the owner of Woodlands Gynecology and Aesthetics and Woodlands Medical Aesthetic Institute in Texas. He speaks for a lot of aesthetic companies. So he speaks for Cyton Laser. We're going to talk a little bit about laser therapy and sexual health, BTL. He also is the faculty of Evexias Health Solutions. So that's a hormone company. And he specializes in hormones and sexual health for men and women. His mission is to help patients look better, feel better, and live better. So please help me in welcoming Dr. Johnny Peet.
Thank you so much. Good to be here.
Tell us, so I'm excited to pick your brain about a lot of stuff because people ask me a ton of stuff about hormones, and I know you spend most of your day talking about hormones and sexual health, especially as an OBGYN. Can you kind of tell people after fellowship tell us the story. What did you do after fellowship, or why did you get into gynecology? I guess that would be a good starting point. And then how you've kind of evolved to today, and what does your day look like now?
Well, I went into OB-GYN because I was really interested in surgery, but I was kind of born to be a primary care doctor. That's to follow my patients long term. My brother, my sister, my brother-in-law, my father are all family doctors. So we being a family doctor in primary care is kind of part of my DNA, but I really liked surgery, so I chose OB-GYN. I spent 13 years in private practice doing all the normal things that the American College of OB-GYN told me to do. I delivered a ton of babies, covered 3 ERs, and was in a large multi-specialty group, and wrote all of the prescriptions that were FDA approved that we had as options. And what I learned was that I didn't know much about hormones or sexual health, and I wasn't trained much about hormones and sexual health other than the few prescription medicines that were out there and available back in the 90s when I was training. But everything's kind of different now. About 12 years ago, I did stop delivering babies and got some sleep at night, which is good, and started really focusing on gynecology. And in focusing on gynecology, it didn't take me long to learn, wow, I don't know much about hormones. I really don't think I was trained in hormones very well. And so I've spent years researching and looking at different types of hormones. And of course, I've evolved into treating a lot of men now because once I started really treating female sexual dysfunction and hormone problems, it led to treating couples, which is what I enjoy doing now, is treating couples together. So our clinic really focuses on female and male hormones and sexual health. So anything that is out there, either in mainstream or on the fringe, we have available at our clinics for this. So everything I do now is during daylight hours, which is kind of nice, and not on holidays or weekends, but it's also actually changing people's lives. And that's what's really gotten our office excited about what we do, is that every day we go in and hear about the success stories that we have for all these couples who really get their hormones fixed, and we have other things we can help to augment and to get their sex life back where it was when they were younger. And perhaps these couples haven't been on the same page now for decades, and all of a sudden they're back on the same page again, and it's really kind of a new life for them, and that's been really rewarding doing this kind of medicine.
Yeah. So I would agree with that. A lot of people, when they first see us, they're very sick. They have a lot of things we need to work on. It's really hard to have good sexual health when you're sick. But as you fix a lot of these things, blood pressure and diabetes and weight and insulin, then you do feel better. And then sexual health is very important. So it is very important. Relationships are very important. Relationships are one of the things that are, keys for longevity. And so sexual wellness is very much a big part of that. So tell us, so you've had a private practice since 2000, and and he's in the Woodlands area, so around Houston, if any of you guys are listening around Houston. And I've been to his clinic. It's phenomenal. He does a lot of really cool things. So you've had this private practice since 2000. What does a day look like for you? So you're not doing surgery anymore. You like to do primary care. So tell us some of the things you guys do in your practice.
Well, it all centers first and foremost around hormones. Testosterone therapy for men, and then testosterone and estradiol and progesterone therapy for women, and then also thyroid. Thyroid's not a huge part of sexual function discussion, but it's a huge part of function in general and well-being. So thyroid is a big part of what we do. We spend a lot of our time with our patients first fixing their hormones and their vitamins and their nutritional status and their health. Diet, exercise, the proper supplements and hormones. We always start there. We try not to jump right into all of these interesting and exciting procedures that we have to help sexual function if we don't fix the basics. And the basics are hormones, diet, exercise, nutrition, and supplements. And you can change a lot of lives just by doing that. So most of what we're doing is counseling patients, helping for them to learn about the importance and the safety of hormones like testosterone and what they do for quality of life, and then really getting them on the proper supplements, and then bringing them back and saying, okay, where are we still having trouble? Where is it that you're still having functional issues, or that you need to improve your life or your relationships? And then we go there. And if we identify that we're still having some erectile dysfunction issues, or we're still having, for women, either lack of desire or a lack of arousal or problems with climax, then we start to identify these issues that are still there, and then pick out the therapies that are best suited to help each of those things. We don't necessarily start right off with these treatments. We really want to get the basics done first, and that's hormones and vitamins and supplements and nutrition and things like that. But we do a lot of lasers for women. Of course, we have cosmetic lasers for the face and body, but also we have vaginal lasers that help to rejuvenate the vaginal tissue and really are life-changing with regard to lubrication, arousal, orgasm, and also urinary incontinence, genital urinary syndrome of menopause. The lasers do a really good job with that. I'm not sure how much farther you want me to go with all the treatments, but we have.
Well, we'll take it in steps. So I love Dr. Peet's approach to this because it's very similar to mine. So, we talk about the 10 stages of wellness, and he just mentioned like pretty much stage 2 through, 7 of mine. So he points out, you guys, it's very important, like you said, go back to the basics. So you have to talk to people about their vitamin deficiencies and about their diet and about their exercise, and then hormones, which are very important. So sex hormones, thyroid hormones, those basic things, if you don't get those right, then it doesn't matter, what else you do. And that's what I tell my patients. Like, if we don't have these things correct, it doesn't matter what therapy you do, you're not going to feel well, right? Sleep is also something that's really important. And so why do you, so people ask me this all the time, and I'm sure you get this. Why are hormones important, Dr. Peet? Like, what does it matter? I went through menopause. Like, why do I need hormones?
So essentially, you may see a lot of clinics popping up around the country that do quote unquote age management or anti-aging or things like that. And I kind of tell those folks, if you're not doing hormones, then that is the first and foremost step towards aging gracefully and healthy and with vitality and with quality of life. If you're not doing hormones, then that clinic is not doing anything towards age management. The word hormone in the Greek means to set in motion. So we have receptors on cells all over our body, and those receptors are waiting for very specific hormones to find them and to bind them. And when they bind those receptors, something in the cell happens. It sets in motion events that change how that cell functions. So if we have receptors everywhere, but our thyroid hormones are low, our testosterone is almost gone. And in menopause, if you're a female patient, you don't have any progesterone or estrogen, you have these receptors that need that hormone to serve a function in the body. And if they don't get it, then whatever was supposed to be set in motion isn't set in motion. So we talk about this with low testosterone in men, and it's kind of an analogy, but these guys with low T, they don't get off the couch. If you don't have testosterone to hit their receptors, you're never going to get them set in motion. They're never going to lose weight and exercise and having the energy to do those things. So hormones are absolutely vital. We don't get old and then lose our hormones. We slowly lose our hormones and then get old. And that's a big, big difference. So if we can maintain the same type of hormones that we had when we were in our 20s, and we can maintain that throughout our 40s, 50s, and 60s, we will age differently. All of those little things that are difficult for aging patients are much easier to deal with and much less of a problem when you have your hormones, what I call optimized.
I love that. We slowly lose our hormones and then we get old. Yep. I'm going to have to steal that from you. Okay.
Well, I guess maybe it's the most true with thyroid and testosterone. Those are slow processes that happen over the course of decades, and we adjust and we adapt and we overcome. And so we fight through it. It's not so much like that when you're talking about menopause for women, because when they go through menopause, estrogen and progesterone go from 100 to 0 overnight. And so thyroid and testosterone is a slow decline. And then once you lose estrogen and progesterone, a whole other bunch of things happen. But that's not a slow process. It happens within a year. But there's so many different problems that occur because we don't have those hormones protecting our brain and our bones and our heart and all of those things that it was protecting in the early part of our life. But you can steal that phrase if you want. That's fine.
I love it. Yes. So, and I say this all the time, estrogen, testosterone, thyroid, it is all very important. Progesterone as well, very important for mood and sleep in women. And so, you said as you get older, I want to point out to listeners though, like some people unfortunately go through menopause a lot younger, right? So there's premature ovarian failure, there's surgical menopause. I have patients in their 20s, young guys in their 20s that have low testosterone. And so a lot of this, I think, you can weigh in on this, but our terrible lifestyle in this country, right? So we don't sleep right. We don't exercise. We eat processed foods. We're just terrible to ourselves. I think that's causing a lot more people to age prematurely or lose their hormones prematurely. And so, if you are having symptoms, you're really tired, you're losing muscle mass, you're having issues sleeping, your mood's bad. As a woman, you're having vaginal dryness or hot flashes. As a man, same thing. If you're losing muscle mass, you need to get these things checked, right? And then when you check them, the other issue is there's this huge wide range of like what is normal, 200 to 900, which is insane. Like that's a normal testosterone for a male. And so I like the word optimized that you use. Patients need to really realize that there is a normal range, but there's an optimal range, and it's based off your symptoms as well, right? And so you kind of have to be your own best advocate, and then you have to find a provider that understands that and knows what they're talking about and has had some good hormone training, which I know you have. So those were all good points. So I get asked a lot, and I'm sure you do too, right? So I answered this question 5 times today. Well, don't hormones cause cancer?
Yeah, there are some hormones that do, and those hormones are synthetic hormones that were created in a lab somewhere and not created in your body. And I ask patients this question, and I ask providers this question: if you made as a female testosterone, estrogen, 17 beta estradiol, and progesterone in the womb before you were born, can those things be dangerous? Do we evolve to create cancer-causing agents from even before we're born? Of course not. Of course not. So why would we think that 17 beta estradiol, testosterone, and progesterone, things we've been making since before day one, and we didn't have cancer when we were kids or teenagers or adolescents or even middle age or younger, why would those things suddenly now all of a sudden be cancer-causing agents when we get older? It doesn't make any sense. We don't evolve into creating cancer-causing things. That's not how plants or animals do things. So it doesn't make sense. So how do we figure out what the real problem is? If you look at the literature, almost every single study that shows that hormone replacement therapy, which is a very broad term, causes or increases cancer, it has to do with a synthetic progestin, not progesterone, but progestin. Every single study is looking at pretty much medroxyprogesterone acetate. There are no studies that show that 17 beta estradiol increases the risk of breast cancer. None. There are no studies that show that progesterone increases the risk of breast cancer or any other cancer. There are no studies that show that testosterone increases any cancer. As a matter of fact, androgens, which is the general term for testosterone and those other hormones that are similar to it, are protective against cancer. It's why when we're younger and we have higher levels of those androgens, both men and women, we have much less likely to develop cancer. We develop cancer after we lose our hormones. And low testosterone is an independent risk factor for testosterone for prostate cancer. So just having low testosterone puts you at risk for having prostate cancer. It is exactly the opposite of what the media wants to tell us, because whenever Big Pharma makes a new drug, they're making a drug that is different from your hormone. Big Pharma cannot patent a natural molecule that occurs in nature, such as testosterone. They have to make a different molecule that's a little bit like testosterone, or a different molecule that's a little bit like progesterone, because you can't patent something that already is in nature. And just in doing that, we create a lot of issues with cancer formation and risk. So the other problem is most of these available hormones are given orally. And we know that when you take oral medications that go through your liver, you increase risk of other things like blood clots and in your lungs and legs. And so you hear all these horrible things that hormones do. Well, if you don't take a pill and you don't take a synthetic hormone, none of those risks really occur. You have to use the proper molecule in the proper delivery system in the proper dose. And if you do that, then you're going to be as healthy on those hormones as you were when you were 20 and you had all those hormones in your system.
Yes, I like that. You have to use the proper hormone in the proper delivery system in the proper dose. And there are a lot of people out there who have no idea what they're doing. And so I clean up a lot of those messes. I'm sure you do as well. And so then I think that's where hormones get a bad name, right? But it's so true. Like if you look it up, testosterone, we used to treat women with breast cancer with high doses of testosterone prior to chemo and radiation, right? And so testosterone doesn't cause cancer. There's a lot of studies that show it's actually protective and beneficial, but yes, progestins, they do cause cancer, but not, bioidentical 17 beta estradiol and testosterone. And so that's what I've been saying for years. And sometimes I, get a little bit of backlash with that, but that's okay. And
I try to be patient with folks, because I remember with 13 years in private practice, I didn't know anything about hormones, and I'm a board certified OBGYN. I mean, I did not know anything about hormones that I needed to know. So I don't make people feel bad about that. But yes, we clean up a lot of messes and we try to educate folks. But the things that we needed to know about hormones, we were not taught. Most people went through their entire training and never even treated a patient with testosterone in their entire training, and were never taught how to do it or what the proper dose was.
Yeah. And to your point, so you went through an OBGYN residency in the United States. I went through an endocrinology, diabetes and metabolism residency in the United States, and I didn't learn anything about hormones either. I definitely did not learn anything about treating women with testosterone. You don't learn about bioidentical hormones, creams, pellets. You don't learn any of that, which is kind of scary, right? And so I am also very patient with people, and I do try to talk to them about the literature. But I think the WHI, scared a lot of people, and then you just have all these doctors that don't know any better, and it's frustrating because I'm like you, I put these people on hormones and then you see it changes their life. Like they start to feel so much better. And to your point, I tell people this too. Like I had a lady today who came to see me and she had every complaint in the book. Like I have dry skin, my hair is falling out. I've gained 50 pounds. I don't want to get off the couch. I have brain fog, yada, yada, yada. And she's 53. And I said, how long has this been going on? 3 years. What happened 3 years ago? Or sorry, she said 4 years. And I said, well, what happened 4 years ago? And she was blaming it on COVID. And I said, well, what else happened? And she goes, well, I went through menopause. And I said, because I knew, I could tell by the timeline. And I said, okay, well, you don't think that had anything to do with it? And she's like, well, no, because hormones are bad for you and cause cancer, right? And so then I always ask people, especially women, well, how did you feel when you were pregnant? And she looked at me and she almost cried. And she said, I never felt better in my life than when I was pregnant. She was like, I can't remember feeling better, even though I was bigger. My mood was great. My skin was great. I slept well. And I said, well, yeah, because you had a whole bunch of hormones, right? Like you're full of progesterone, you're full of estrogen. And so anyways, we're going to check her hormones and we're going to make her feel better. But it's just, it's alarming how many people like don't put that together, right? Like this lady. And then when I said that, she was like, yeah, that's actually true. Like that's when it all happened, was when I stopped having my period. So it's interesting.
One of the big problems that we face as providers in treating androgen deficiency in women or low testosterone in women is that there is no currently available FDA-approved treatment with testosterone for women in the U.S. There's nothing available. So what that means is every time we treat a female patient for low testosterone, which is very easy to diagnose, androgen deficiency in women, we have to do it off-label because there's nothing available. And because there's no FDA-approved product available, then the residency programs are not going to teach anyone how to treat this condition because there's not an FDA-approved product to use. So androgen deficiency in women is marked by three main things, the syndrome, and that is unexplained fatigue, sexual dysfunction, and mood problems. And if I have a patient in middle age, even if they're not menopausal yet, if they have that triad of symptoms, 9 times out of 10, that is testosterone deficiency in women. And when you use bioidentical testosterone, of course, we prefer pellet therapy because it's the smoothest blood level and the safest delivery system. All of those symptoms go away. But because there's no FDA-approved product for that, it's off-label therapy. And too many people are afraid to do off-label therapy, or they just never were taught that because it's an off-label treatment.
So you bring up pellets. I was going there, but since you brought them up, so there have been some podcasts recently, one of which I used to love and thought a lot of this lady, but she brought a OBGYN on her podcast who just reamed pellet therapy and talked about how terrible it was and how it wasn't FDA approved. I mean, she just reamed it forever. But then at the end, she said, and just so you all know, I've never done hormone pellet therapy, and I don't really know a lot about compounding hormones. And I was infuriated because this was a very big podcast, had a huge platform. Millions of women listen to this podcast, and this ignorant OBGYN just, destroyed all these listeners with her misinformation because, again, she has no background or knowledge in compounded. The only thing she wanted to talk about was estradiol patches and how that's the only safe way to take estradiol because it's FDA approved. She never mentioned testosterone. So that got me so fired up, but I digress. So tell everyone tell everyone a little bit about pellets. Why do you think pellets are safe? Because I get a lot of backlash on social media about this. Like pellets are awful. They're not FDA approved. Well, if all we did was FDA approved therapy, we would all be fat and dead a lot sooner than we are now. But that's just my opinion. So let's talk about pellets a little bit. So why do you prefer pellets?
Well, when I started off with bioidentical hormones, I was doing a lot of things that other folks are doing, which like creams and sublinguals and some things like that. And I think patients do get a little bit better, not life-changing, but they get a little bit better. But about 12 years ago, when I was maybe 11 years ago, I was introduced to pellet therapy and started to try to figure out, why is it that these people do so much better? Why are they feeling so much better than these creams that I've been giving them in the past? And it has a lot to do with the delivery system and the pharmacokinetics. If I put a cream on, I may get a good level of testosterone an hour or two later, but then maybe 6 or 8 hours later, it's pretty much all gone. So there's a range where people are going to feel the best. And if you get above that range, you're in side effect area, side effect zone. If you're below that range, nothing's working, you're not feeling any better. So there is an optimal range for men and women, and it's not hard to find. You don't want to get side effects, but you want to have efficacy. But when you take a cream, you're going to shoot up through that zone, and then you're going to fall back down through that zone really quick, and you're not in that zone long enough for your symptoms to really get better. When we do pellet therapy, now, if I compare it to an injection in men, let's say, if I give a shot to a man, on day 2 after that injection, it's going to spike super high, right? And they may not have any problems from that, but you're spiking very high. And on day 5 or 6 or 7, you're all the way back down where you started. So you go shooting up through the optimal range, and then you go barreling back down through the optimal range. And that's why sometimes with men, they're on kind of a roller coaster. If they're doing it every 2 weeks, it's an awful way to do it, because the second week they have no testosterone at all. If you're doing it once a week, you still can feel a little too much at the beginning and not enough at the end. Twice a week actually works pretty good, but you're still going to have a spike after you take it. The beauty of pellet therapy is, number 1, it's bioidentical, but number 2 is that after you achieve that level, which takes a few weeks to get, you're going to stay in that range for months. For women, 3 to 4 months. For men, 4 to 5 months, never dropping down low, so the efficacy remains good, but never spiking terribly high either, so your side effects are minimized. And in women, we're talking about side effects if you were doing a testosterone troche or a cream of maybe acne or hair growth, or these are nuisance side effects. They're not dangerous side effects. For men, you might add in aromatization, a little high estradiol or high red blood cell count. All of those things are amplified if you're using a delivery system that spikes too high for any period of time. Pellets removes that spike when they're done correctly, and it keeps it above the lowest threshold so that the efficacy works. Your symptoms have time to get better, because you may have to have an optimal level of testosterone for several weeks before you start sleeping better, or your mood's better, or your joint pain gets better. And you may not ever get better if you just have an optimal range for a few hours each day, or just 2 days out of each week. You may not be able to reach that symptom relief that you're looking for. And the benefits of bioidentical are essentially, number 1, it's the exact molecule that your body made, which means it fits into the receptor perfectly, number 1. Number 2, it is broken down correctly into the proper metabolites. We have in our body enzymes that break these hormones down so that we can get rid of them. Everything that comes into our body has to be processed, used, or gotten rid of. And if we're using enzymes to break down molecules, but the molecules aren't really the same as what your body made, you're going to have, when you break these molecules up into pieces, little pieces or metabolites that your body doesn't recognize. And that's where you get symptoms and side effects and problems, is by having these metabolites that aren't supposed to be there. So that's the beauty of having bioidentical hormones, is the source is plant-based usually, but the molecule matches exactly what your body was making, and that's the deficiency that we want to correct. Now, the person that had the podcast, if someone asked me to do a podcast on a therapy that I have never prescribed, I would decline to do the podcast, okay? If someone asked me to do a podcast on a neurosurgery topic, I would decline to do the podcast. So many doctors, and you and I have talked about this before, if they're not up on something, if they're not current, they haven't learned it, they don't know what it is, they haven't used it, they're not up on it, they're automatically down on it. And if that doctor has seen maybe 3 or 4 bleeding patients in her office on pellets, she's going to think the whole world on pellets is bleeding. But she's not seeing the 9,000 patients who never had a single problem. She's seeing the ones that complained. And so she's going to have this different view about pellet therapy, one, because she's never done it, and two, because she might just take care of people who had trouble.
Yeah. And my other problem with that too was, again, she knew she was going on this platform with millions of viewers. So it was the Mel Robbins podcast. And I mean, she has millions of viewers. And then this lady goes on there and says, well, I do hormones, but I don't do any I don't have any, I don't use compounded hormones. So I don't even think she used cream. She made a comment about like, I don't even, believe in or use compounded hormones, but she definitely threw around like pellets are terrible and this and that. And it's like, I give her, yes, she's an OBGYN. Sure, she's done a lot of hormones. But if you look it up, I think she was talking about how FDA this, FDA that. Well, I think she gets a lot of money from the FDA. I think she does some studies for FDA too, which is totally fine. But it's like, don't go on there and bash a whole, like you said, don't go on there and bash pellets. Don't go on there and bash bioidentical hormones if you're admitting you don't know anything about them and you don't know how to use them, because that's just what was really frustrating to me, right? That's almost like the WHI. Like, you don't want to go destroy, because again, a lot of people listen to that. And so then I tell my patients to listen to Mel Robbins because I really like her and she changed my life. So then I had patients who came to me and said, well, I listened to Mel Robbins because you said to, and then did you hear that podcast she had with that OBGYN? Why are you giving me pellets? And I'm like, oh, for God's sakes. So it was frustrating to me. Because I completely agree with you. They're very, they're bioidentical. They're very stable. They've changed a ton of people's lives. They've changed my life. You're exactly right. My husband will tell you if I need my testosterone pellet, I do not sleep well. And I do not sleep well for a couple weeks after I get it. So he's very, like on a calendar, like telling my staff when I need my pellets, because he doesn't want me tossing around all night and not being able to sleep. And it's true. Once you feel better. The other thing I think people don't realize is, especially women, don't realize how bad they feel until they feel better, right? Because we just go, 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 go. And then you get to a point where you're like, I guess this is just life. And then when you actually feel better, you're like, oh, wait, wow, So, yes, so I agree with everything you said about pellets, but this is why I brought Dr. Peet on, you guys. He's way smarter than me, OBGYN. Just wanted his personal take and his opinion on this. Here's another question about hormones, and I'm going to kind of transition a little bit. How long can you safely take hormones? I have people who ask me that. So, okay, Dr. Smith, I'm going to start this pellet. How long can I safely take these hormones?
I tell my patients all the time they can take the hormones as long as they want the benefits of the hormones.
That's exactly what I say, as long as you want the benefits.
Absolutely no studies to suggest that there is a time limit on hormones. Some of the people that initially looked at the WHI study started to decide that there was some time limit. And we're talking about oral synthetic hormones, and we're not even talking about testosterone. But oral synthetic hormones, they said, well, gosh, Doc, I just saw my primary care doctor, and he told me that I've been on these hormones for so long that now I have to get off of them. And where that came from, I really don't know. We have good reviews from Dr. Abraham Morgenthaler, a urologist who is the world's leading published author on testosterone for men, and he clearly says there are no age-specific recommendations. As long as they can enjoy the benefits of the testosterone, then they can take it.
I agree. So I want to talk a little bit about low sex drive or low libido in women, and then I want to talk about erectile dysfunction. So we're going to start with women because I'm a woman. So let's talk about, in general, I get this question a lot too. So is it common for women to have low libido?
It's more common for women to have low libido than to have normal libido past a certain age. Okay. And we're not talking about menopausal people. We're not talking about women who've had their ovaries removed. In that group, women who've had their ovaries removed, it's well over 90% have what they consider an abnormally low libido. In menopause, it's probably 70 to 80%. But in this middle age group, this 30s to 40s, before you reach menopause, over half of women will say, you know what, my libido is not like it used to be and it bothers me. And it is extremely common. What we know now is that most women will lose the majority of their androgens or testosterone a good 10 years prior to menopause. So if the average age of menopause in this country is 51, that means that most women have lost the vast majority of their hormones by the time they're in their early 40s. And it is symptomatic and it is problematic. And people don't realize that that's what's happening. That women are losing their androgens. And so if you have a slow decline in thyroid matched with a slow decline in androgens throughout your 30s and 40s, there is going to be mood problems, fatigue, muscle loss, insomnia, all kinds of sexual dysfunction. And what do we do for these women? Well, we just give them an antidepressant and a sleeping pill and a diet pill and all these kind of crazy things just to treat a symptom of a hormone deficiency that we know is there. And if we treat the hormone deficiencies and the nutritional deficiencies and all those things, they don't need all these prescription medications. We don't have deficiencies in SSRIs, and we don't have deficiencies in benzodiazepines and sleeping pills. We don't have an Ambien deficiency. We're not sleeping for a reason. And it's not because we don't have enough Ambien. It's because we have hormone issues that need to be fixed. But low libido is something that is extremely common, and that is because once women have finished their childbearing years, they're going to lose their androgens, especially after they've had several kids.
So it is common, women, for you to have low libido. So there's nothing wrong with you. And like Dr. Peet said, an SSRI is not the answer. So what is the answer? Testosterone?
Yeah. So when I look at all these patients that have so many different problems, and let's not just talk about low testosterone, let's just talk about their function in their life. It's a puzzle, right? It's never just one thing. You can never look at a patient and say, okay, your whole problem is you have 73 complaints. Your whole problem is A, and we're just going to give you A, and then you're going to be well. No, you've got vitamins like B12 and D3. You've got toxicities. You've got lack of exercise. You've got testosterone. You've got thyroid. You've got estrogen. You've got progesterone. If I just mess around and replace a couple of those things, that's like doing a puzzle and leaving out a bunch of the pieces. When you get to the end of the puzzle, you don't recognize the picture, right? But if we're talking about low libido in a premenopausal patient, then you can almost point the finger to one thing every time, and that is testosterone.
Okay. So if a woman is listening to this and they have low libido and they're in their 30s or 40s or 50s, then your recommendation would be to find a provider that will put all those puzzle pieces together. Yes.
Absolutely.
And understands bioidentical hormones. Okay. But there's nothing wrong with them. This is more common than not, is what he's saying, women, if you're listening to this. And so let's say that we go and we get evaluated and we've fixed our vitamins and we fixed our thyroid and we're taking testosterone and we're still having issues with low libido. Then is there something else that you recommend? Is there something else that goes into that? Is some of it mental?
Yeah, it depends on the whole picture. So there's a lot of different categories of female sexual dysfunction. Lack of desire is just one. There's arousal disorders, there's orgasmic disorders, there is pain with intercourse. All these different things affect a woman's desire to want to have sex. If it hurts, then she's not going to want to do that. That is a natural instinct called pain avoidance. So if there's discomfort with intercourse, then no one's going to have a libido. That's very, very normal. And testosterone, fortunately, treats every single different disorder in sexual function in women. It treats low libido, it treats arousal disorders, it helps with discomfort and lubrication. It also improves orgasm. So everything about sexual function is improved with testosterone, and that's a good thing. Now, we do have some other things for, let's say, discomfort or dryness or pain, right? So we can treat the vaginal lining. We can use topical estrogens. We use vaginal lasers. I use a laser called Diva by Cyton, which is a fractional hybrid laser. So it actually drills tiny little holes in the vaginal lining, and then when it regrows back, it grows back thicker and healthier, and lubrication's improved, sexual response is improved, laxity is improved, so the sensation's better. So vaginal lasers really help. I also use a device called the Imcella device from BTL, which actually helps you to work your pelvic floor muscles by causing you to have 11,000 Kegels in 28 minutes. It's electromagnetic chair. Pelvic floor muscles play a role in sexual function. If you can make the whole process more enjoyable, then it's easier for libido to respond. If everything's better, your libido will eventually improve. Now, in a menopausal patient, lack of estrogen will also affect libido some as well, and some adrenal hormones that can be low can affect libido also. We do use some peptides for female sexual function, such as oxytocin, PT141. Those are beneficial for sexual function. There's a lot of things out there. The key is fix the hormones first, and then go see where you've made improvements and celebrate those, but then go and focus on where you still need to really make some headway. And so focus on those things, and then we've got a lot of other things in line that we can do.
So I hope women, if you're listening to this now, you feel a little more motivated to get this looked at if you are having issues with low libido, and knowing that, you know, testosterone is definitely where you need to start, like Dr. Peet said, but there are lots of other options. So there are laser therapies. And like I said, I've been to his office. He does all of this. So the Diva laser, there's peptides, PT141, oxytocin, which we offer those as well at our office. The Mcella machine, I do not have one of those, but he does. And I sat on it, and it is intense. It's serious. And so those things will help as well. And then I know you do some O shots and some P shots as well. So Dr. Peet actually was the one who taught me how to do these. So he's done a lot of them, done them for a long time. And so do you want to kind of explain that a little bit?
Sure. So this all started with platelet-rich plasma, which is something that we've used a lot in aesthetics over the years. It has a wide range of applications. Essentially, what we do is draw blood from a patient, take their blood, spin it down, remove the red and white cells, and we're left with plasma and platelets. It's a clear yellowish fluid, and it's full of just platelets and the plasma. You can take that and inject it somewhere in your body and cause the tissue to regenerate and grow. And when we cause tissue to regenerate and grow, the function changes. So what I tell people is, if I were to cut my arm, the reason that I don't bleed to death is because there are platelets that stick together and form a clot. But that's not the only thing that they're doing. They're not just stopping you from bleeding to death. When they clot, they release growth factors into the bloodstream and into the surrounding tissue that act like a bat signal to your stem cells to come to that area and see what in the heck is going on. We need to fix something. And then your stem cells know that we need to fix hair follicles and epidermis and dermis and subcu fat and blood vessels and nerves that have all been injured by this cut. So your body goes about the healing process. And if you grow new nerves and new blood vessels in an organ, you're going to get way more function. Everything's going to work better. So when we take platelet-rich plasma or growth factors from the placenta, other type of things that are similar, and we inject those things into the sexual organs, in the anterior vagina and in the clitoral glands and shaft, when we inject those things, your body thinks that there's been some sort of an acute injury here. And your body goes to that area with your stem cells to regenerate and rebuild tissue. So we're actually tricking your body into thinking that you've had an acute injury, and we're triggering your own body's healing response. Now, your body doesn't know that this is really a chronic injury. This is aging and lack of hormones and high blood sugar and hypertension and smoking, and all these things that have injured this tissue are chronic, but your body doesn't know that. Your body knows that there's growth factors there. What's going on? Let me go fix this. So when we inject into the male cavernosa in the penis platelet-rich plasma, it sends the same signal, and your body knows how to heal if it's given the right mechanism and the right signals. And it works very, very well.
That was a great explanation. Yes. So O shots and P shots. So then that's a good segue and a transition into erectile dysfunction. So let's talk about that as well. So in men, what is a common age for this to happen? Is there an age that it happens where it's too early? What are the causes of it? I get lots of questions about that. So what's the typical age when you start to see men have erectile dysfunction issues?
Most commonly in the 40s. However, I mean, it was thought not long ago in medicine, just a couple decades ago, that all erectile dysfunction was psychogenic. It was all between your ears. But then we got Viagra. And if Viagra works, then it's not between your ears, right? If it was between your ears, Viagra wouldn't work. It works on the blood flow. And so only the last couple of decades have we realized that this is really, truly a blood flow and nervous problem. And this is something that needs to be treated medically. It's a medical condition. It's not a psychiatric condition. Now, in folks that are very young, that have erectile dysfunction, who have normal erections when they're by themselves, but erectile dysfunction when they're with a partner, that's more psychogenic. But that happens in more younger clientele. As we get older, we suffer from first the loss of testosterone, which begins in our 30s, right? And then as we get older, we're adding on hypertension, vascular disease. We're adding on elevated blood sugar, which ruins every single thing in your entire body when your sugars are elevated. And I know this is probably something that you harp on every day. You cannot function normally if your sugars are elevated. So you're talking about hypertension, diabetes, low testosterone, all of it adds up. And then you also have to throw in there so many prescription medicines and so many over-the-counter medicines that adversely affect erectile function in men. And I still to this day receive consults every week, and the consults for the men come in, they're here to get a P shot. That's why they're there. They want a P shot. Well, the first thing I ask them is, well, when's the last time you had blood work drawn? You know, what is your hemoglobin A1C? What's your average blood sugar? What's your testosterone level? What's your estradiol level? We're not going to go to step 10 if we haven't done steps 1 through 9 yet. And so most of these guys, although they're willing to give me a whole bunch of cash, they don't get that procedure until we go through this whole wellness lab exam and start to identify things that need to be fixed. It's important to lower inflammatory markers and to have B vitamins and D vitamins, all of those things. But once you've fixed all of that, typically the testosterone will have effects on erectile function within a month. Guys will start to see increase in morning erections. That doesn't necessarily mean they can sustain the erection for intercourse, but within a month of starting testosterone, they'll start to see morning erections again, and that'll give them some hope that things are coming back. Usually I will recommend a low-dose daily Cialis to start with if testosterone alone is not enough to fix the problem. 2.5 or 5 milligrams once per day has very few side effects, actually helps some prostate issues, and definitely helps erections. Getting off of prescription medicines that you don't need, watching the over-the-counter medicines that cause problems, fixing testosterone, and utilizing a low-dose daily Cialis, that will correct erectile dysfunction in at least 80% of men that come to my office who complain of it.
And so for the listeners, let's explain why. So when you have erectile dysfunction, giving somebody testosterone, giving somebody low-dose Cialis, these things are vasodilators, correct? And so the vasodilation is going to help with blood flow to the penis, but then also the testosterone is just going to help with the mood, right? So it's going to help with the desire, the mood, give you the energy, things like that. And then yes, getting rid of, the supplements or getting rid of the medications that you don't need because they have bad side effects. And glucose, that's where I kind of start with people. Insulin is one of the most inflammatory molecules in your entire body. 93% of the adult population have insulin levels that are above 5, which I consider high. When you have high insulin levels and high glucose levels, everything is inflamed. And so it's much more difficult to do anything. It's hard for your blood to flow through your penis or through your kidneys or through your heart or through your brain. And so it's more difficult to just be well in general. So what Dr. Peet is saying is, with testosterone, fixing that in men, that will help with desire and then a little bit of vasodilation. And sometimes we throw into, so all the things you said, I agree with. Sometimes we throw in a little nitric oxide supplement as well to help with blood flow. And so those things, so if there are men out there listening to this and they are having issues with erectile dysfunction, number one, no, even if you're in your 30s, it happens. There's nothing like terribly wrong with you. I do agree though, that if you are having erectile dysfunction, a couple of things, you need some blood work done, because the question is, is this just, if you are younger, is it, psychogenic, or is there something else that we need to fix, right? Like, is this kind of like a check engine light? Is your glucose okay? Is your thyroid okay? And then if you are in your 40s, this is very common. Men, I see a lot of men in their 40s and they don't necessarily want to talk to me about it at first, but it's very common in your 40s. It's nothing to be ashamed of. It's nothing to, I mean, it happens just like women go through menopause. And so you do need to talk to someone about it though, right? You need to be comfortable finding a provider to talk to about it because it's an important part of life, sex is. And also what I tell men is if you're having erectile dysfunction, you probably know this study, men that have erectile dysfunction, it's shown that 1 out of 6 of those men, so about 15% of men from the time you have erectile dysfunction within 7 years will have a cardiac event. So if you have erectile dysfunction at 40, there is, a 15% chance in the next 7 years you're going to have some sort of cardiac event because of that, because the blood flow to your penis is the same as the blood flow to your heart, is the same as the blood flow to your brain. And so you just need to address these things and know what's going on and figure out how to fix them, right?
Absolutely. And when someone comes into my office with erectile dysfunction, the first question I ask myself is, what else is going on? Because this is just a sign of a deeper problem. It's the tip of the iceberg, not to make a bad joke, but there's something else. There's something else going on that we need to find out and fix. Because, if someone comes into my office and their complaint is ED, and all I do for them is give them a Viagra prescription, we're just treating a symptom of a greater problem, and we're ignoring that greater problem. We need to fix the root cause, and hopefully they don't need all of these other things. What they really need is someone to get them healthy.
Yeah. And we hear this all the time, right? Or this is what we learned in school. Somebody has ED, you give them Viagra. They don't even really teach you about testosterone. They definitely don't teach you about glucose or A1C, or it's just like, well, that's what Viagra is for. And if you do that, I don't do that, but if you did that, I bet it would not even work 5% of the time, right? If you have somebody who says, I just have ED, maybe 5% of the time I don't know, but most likely that's not going to work just on its own, right? It's a little bit of vasodilation. It's not going to help their androgen. It's not going to help the root cause. It's not going to help them feel better. And so the FDA, approved treatment for erectile dysfunction men is not doing y'all any favors, in my opinion.
And I see this all the time. These men they go see a urologist. I don't know how many urologists you have listening to the podcast. I'm not going to bash urologists, but they'll go see the urologist. They won't even have labs drawn. They'll get Viagra. It will work for a few months because your body hasn't seen that before. And it goes, whoo, okay, now I've got a little nitric oxide here. I'm going to vasodilate, and it'll work, but it'll be short-lived. 6 months, a year later, they're taking 2-3 times as much, and it's not working anymore. And then they'll go back to the urologist, and unfortunately, at that point, they get Trimix, right? Which for me is about step 13 of 15, 15 being an implant, right? Literally the last thing. So start with testosterone. And I was told by urologists when I was in training that testosterone really doesn't help erections. And now I know that they didn't know how to replace testosterone, right? Because it helps erections in every single person we replace testosterone with when it's done correctly. So we start there. And then from that point forward, if they're still having trouble and they want to do a P-shot, we'll go right into a P-shot. We'll talk about shockwave therapy, which is a good adjunct. And then also the Emcella chair for men helps. PT-141 is fantastic. There are some peptides out there that help. We use penis pumps as well and shockwave to augment the P-shot. I don't use a lot of shockwave therapy standalone. You will see some clinics that open up that just want to do shockwave therapy. You come in, they'll give you a free ultrasound, which is fairly useless, and then they will sign you up for 12 sessions of shockwave therapy. Well, you're going to have an improvement in your erections during that treatment and for a little while afterwards. But none of the problems that led you there are fixed. So you're still going to be right back where you started. I almost never do shockwave therapy as a standalone therapy. It's an adjunct after the P-shot is where we use it. I'm sure I could sell a lot more shockwave therapies, but I wouldn't be doing anybody any benefit using it as a standalone treatment.
Yeah, I agree with all of that. So that is why I asked you to be a guest on my podcast, and I appreciate you for coming on because, I think we think very similarly, which is you can't just kind of Band-Aid or fix things. You really need to go back to the basics, back to the root of the problem, and then have steps. And testosterone hormones are a big, it's at the lower, it's at the beginning of the steps as far as my process goes, but it's also fixing your diet and doing some blood work and making an educated, treatment plan with the patient. based on the entire picture, not just on one symptom or just one thing, like, like some of these pop-up clinics do. Like, let's just hammer everyone with testosterone and give them all the same dose. They all get 200 milligrams of a shot twice, once a week or whatever. I mean, that doesn't work. It's not a one size fits all. And you really do have to look at everything in order to make people better. And, hormones are a huge part of health. They help with brain health, like we were talking about. They help with bones. They help with, fatigue and muscle mass and sexual health. And sexual health is very important, which is why I wanted to talk to you about this. And I wanted people to be more comfortable talking to a provider about this. And so I hope that this podcast helps people have some ammunition or have some answers to some just basic questions about hormones and about low sex drive and about erectile dysfunction, so that they feel more comfortable going to their doctor and they know that they actually need more than just Viagra, or they need more than, just an SSRI. And so I do appreciate you helping me educate people about this. If anyone listening is in the Houston area, I'm going to link all of Dr. Peet's stuff. Like I said, I went to his clinic. It's amazing. He practices like I guess I practice like he does, I should say. I practice like he does. But we're both very like, go figure out the root cause, figure out, the source of the problem. We both agree that bioidentical hormones are the way to go. We also both agree that pellets are a great way to treat people. I'm not saying that everyone has to take a pellet. I think people do better on pellets, just like you. I have people who take creams, synthetic hormones, not so much. I don't like to prescribe them, but I just wanted to get somebody else's opinion. And I think you do a great job of explaining things. So I hope people, enjoyed that and learned. I have 3 questions that I end every podcast with. So I want to ask you my 3 questions, if that's okay. Okay. So what is one food, if you have to pick one food that is the most beneficial, what is that one food and why?
The most beneficial for everyone, or the food I like the most?
Well,
let me see here.
Remember, this is a health podcast. But you could pick the food that's most beneficial for your libido or your testosterone or whatever.
I'm a really big believer in avocados. Is that
okay?
I don't know. It's a good fat, right?
Good fat. That's a great answer. I eat avocado almost with every meal. I love avocado. I love it. So I think that's a great answer. What is one easy health tip that anyone can do that's free?
Well, I personally like when people spend some time in the sun. I know the dermatologists aren't so fond of that, but walking outside in the sun a little bit every day is good for you.
Okay.
Which is one of the reasons why the pandemic was so dangerous for folks, because no one went outside.
I would agree. I go outside and walk in the sun every day, when it comes up and when it goes down. What is one thing you wish you would have known about your health 10 years ago that you would have done differently?
Hmm. 10 years ago, when did I start on testosterone? I started on testosterone about 11 or 12 years ago. So it wouldn't be that one, but that was the biggest one for me, is finally realizing that was what the problem is. 10 years ago, where was I 10 years ago? The GLP-1s have been pretty big. Re-ask your question again. Is it about me or my patients?
Just in general, one thing you wish you would have known about your health 10 years ago. Would you have done something differently? Would you have eaten differently? Would you have slept differently? Would you have, what would you have done?
Yeah, I wish I'd have known a little bit more how to fast and get my insulin down. I was struggling with weight 10 years ago. And even though I ate healthy, I ate too often. And I ate the wrong stuff. And now I don't ever have a calorie before noon for the most part. And whenever I check my insulin or blood sugar and A1C, I'm down below 5% now on the A1C. And it really helps to get your insulin and blood sugar down. So however you fast, there's a million different ways to do intermittent fasting or time restricted eating or all those kind of things. I feel like there's a million ways to do it, but getting your insulin and your sugar down is so important just for your overall health long term.
I would agree. So fasting. Okay. So I lied. There's one more thing I want to ask you. I skipped over it. I'm sorry. Because you're also like a pro at this. Do you think that ozone has any benefit as far as ED, low libido, just in general with sexual health and wellness? Ozone therapy.
I wouldn't know about libido so much, but I would say for sure that any vascular issue, any blood flow type of issue is going to improve when we utilize ozone therapy. So when we talk about what's the most important thing that a person needs, right? We can argue about this forever. Is it we must have food? We got to have water. No, it's oxygen. You can't live without oxygen for a minute, right? And so I think a lot of our body sometimes is starved from that because of our poor blood flow and tissue perfusion and all those other things. And when you add ozone therapy, anything that is related to vascular blood flow is going to be improved, right? So we all know that if how your brain functions if you're too tired or don't have any good blood flow to the area. So I mean, there's a million things where ozone helps, but it's mainly just giving you the most important molecule that a human needs, and that's oxygen. Can't live without it literally for a minute. Not sure on libido. Certainly it would improve sexual function because it kind of improves all of your function.
Yeah. And it definitely helps with any inflammatory condition. So these people that come in that do have ED or issues with libido that are chronically inflamed from high insulin, poor diet, autoimmune conditions, vitamin deficiencies, things like that. A lot of times they're all tied together, right? Your insulin's high, so you've got inflammation of your gut. So you're not absorbing your micronutrients from your stomach. So it's just a big mess. But ozone's going to go and help with all that inflammation, right?
It's often the piece of the puzzle that isn't addressed. In other words, you've got some of these people that we've done everything with, and they're just not quite where they need to be health-wise. And we do a course of 4 or 5 ozone therapy treatments, and everything is exactly where it needs to be now. It's one of those things that we leave out sometimes, and it should be a more integral part of the big puzzle instead of just a last-ditch effort at trying to make someone feel better.
I agree. Sorry, I had to pick your brain about that because I don't know a ton of people who actually do ozone. And so I just wanted to get your take on it as well. So thank you so much for taking the time to come help educate my listeners. And like I said, we'll link all of your stuff. I super appreciate it. And I look forward to being able to come back to your clinic and learn more in the future.
Well, we definitely need more endocrinologists like you in the world. That is for sure.
Well, thank you. And thank you guys for joining us on Back to the Basics. Make sure that you tune in next week. Make sure that you like and follow us. If you thought that this was beneficial at all, please make sure that you share this with somebody. I think it was a lot of great information. I know you know somebody who's struggling with something that we talked about today. And then keep in mind, if you live in Arizona, Ohio, Oklahoma, Illinois, Georgia, Michigan, Nevada, or Texas, that Modern Endocrine can see you now. We do virtuals in all of those states. So just keep that in mind. See you next week. The information presented, including any materials discussed, referenced, or linked within this podcast, are for general educational purposes only, not the practice of medicine. No doctor-patient relationship is formed from you listening to this podcast or utilizing any of the information provided. I am a doctor, but I am not talking to you as your doctor. The information provided is not intended to diagnose or treat health problems or take the place of the professional medical care provided by your doctor. If you are experiencing any health problems, including problems you believe have been touched upon in any respect within this podcast, you should consult your doctor about the problems without delay. You may ask your doctor whether he or she believes the information I have provided would be helpful to you, but you should still consult your doctor immediately and follow his or her medical advice as your treating physician. I'm just here to provide you basic knowledge about the issues we discuss so you are more aware of them and can better discuss them with your doctor. That's why we call it Back to the Basics. Join me on the next episode as we continue our journey.